Let's talk about one of the highest stakes balancing acts in all of medicine, managing anticoagulation during pregnancy. It's tricky for sure. So today, we're breaking down the playbook, a clear, actionable guide to help you make the absolute safest choices for both mother and child.
So, picture this. You've got a pregnant patient and she needs anticoagulation. The risks? They're high. The drug options? They're very specific. And the timing? Oh, it's absolutely critical. This explainer is all about giving you the confidence you need to navigate this exact scenario.
We're going to walk through this in 5 clear parts. First up, we'll cover the why, the diagnoses that get us here. Then, we'll dive into our safest tools, the heparins, and follow that up with the drugs you need to stay away from. Finally, we'll map out the game plan for delivery and that all-important postpartum period.
All right, let's start at the beginning. Before we even think about choosing a drug, we need to be crystal clear on the clinical reasons that put a patient in this situation in the first place.
You know, the reasons for anticoagulation in pregnancy are always serious. We're talking about things like antiphospholipid syndrome, preventing or treating dangerous clots like a DVT, managing prosthetic heart valves, or even underlying inherited conditions. Every single one of these carries a big risk that makes anticoagulation a must.
So, what are our go-to options? This brings us to the real heroes of our playbook, the heparins. These are the drugs you're going to be reaching for most of the time, and believe me, it's for a very good reason.
And here it is. This is the single most important rule, the principle that guides every single decision we make. The anticoagulant must not cross the placental barrier. That's the whole game. By using a molecule that's too large to pass through, you can treat the mother without directly touching the fetus. This is the absolute, non-negotiable foundation of safe therapy.
So, in our toolkit, we've got 2 main players, the heparins, and they each have their own strengths. Low molecular weight heparin, or LMWH, is awesome. It's predictable, you don't need to monitor it, and it has a lower risk of that nasty complication, HIT. It's perfect for outpatient use. On the other hand, you have unfractionated heparin, UFH. Its biggest advantage? It has a super short half-life and you can reverse it with protamine. That makes it the top choice as you get closer to delivery.
Now, let's talk about the flip side, because just as important as knowing what to use is knowing what not to use. This section is all about the drugs you absolutely have to avoid.
And the first big warning is for a drug that we're all familiar with, warfarin. But in pregnancy, it demands extreme caution.
And here's why. Unlike the heparins, warfarin is a tiny molecule. It just sails right across the placenta. If a fetus is exposed during that critical window of 6 to 12 weeks, it's known to be teratogenic. It can cause a very specific pattern of birth defects. Now, you might see it used in some very rare, super high-risk cases with mechanical heart valves, but the default move is always to switch to heparin before a patient even conceives.
And then we've got the direct oral anticoagulants, the DOACs. The message here could not be any clearer. The Bigatran, Rivaroxaban, Apixaban, all of them, they are absolutely 100% contraindicated. There's just not enough safety data. So you avoid them in pregnancy, you avoid them in breastfeeding. Full stop, no debate.
Okay, this brings us to the most dynamic, most intense phase, managing the patient right around labor and delivery. This is where your timing, your communication, and having a rock-solid plan, well, it's everything. Think of this as the delivery countdown. Around 35 or 36 weeks, it's really common to switch patients from LMWH over to UFH. Why? It's all about control. UFH's short half-life means we can manage bleeding risk much more precisely. And this leads to some very clear stopping rules. 24 hours for therapeutic LMWH and just 4 to 6 hours for a UFH infusion before delivery. It's all about minimizing that bleeding risk when it matters most.
And this timing becomes life or death critical when we talk about neuroaxial anesthesia, like an epidural. I mean, to prevent the catastrophic risk of a spinal hematoma, these time windows are completely non-negotiable. You have to wait 12 to 24 hours after the last LMWH dose, and for UFH, you wait until the APTT is back to normal.
So, the baby is here, everyone's safe, but our job isn't done. The postpartum period actually carries its own very high risk of thrombosis, so we need a clear plan for safely restarting that anticoagulation.
And thankfully, the plan is pretty straightforward. For a vaginal delivery, you can typically restart in about 4 to 6 hours. For a C-section, you're going to wait a little bit longer, usually 6 to 12 hours. And if the original reason for the anticoagulation is still there, you're generally going to continue that therapy for at least 6 weeks postpartum.
Now, what about breastfeeding? This is a huge question we always get. Well, we have several safe options. The heparins, they don't pass into breast milk. And, surprising to a lot of people, neither does warfarin in any significant amount. So both are considered safe. But look at the bottom of that list. There's that hard stop again. DOACs remain firmly contraindicated.
And of course, through this whole process, we have to stay vigilant for complications. Bleeding is the obvious one, but we also need to be watching for things like HIT, which is more common with UFH, and just be aware of the risk of osteoporosis with very long-term heparin use.
So, if you're going to remember just one thing from all this, let it be this. LMWH and UFH are your safest go-to choices. Warfarin is a teratogen, reserved for only the highest risk situations. DOEGs, they're out. And your plan for delivery has to be meticulously, perfectly timed with stopping these drugs. That right there is the core of the playbook.
So the information's here, the guidelines are clear. The only question left is, how are you going to apply this playbook to navigate the complexities of your next case and ensure the best possible outcome for both mother and child?